All right, good evening, everyone, and thank you for joining the Oculus Clinical Webinar Series. My name is Dr. Bill Tullo, a Chief Medical Officer at Oculus, and I'm really excited today to bring two amazing speakers to our presentation. Dr. Ken Maller, again, is our local expert in orthokeratology and all things contact lens fitting. And we also have Dr. Jen Harthan, professor of optometry at the Illinois College of Optometry. She's going to talk with us a little bit about the prevalence of keratoconus in the pediatric population. Dr. Harthan, take it away.
Thanks, Bill. I really appreciate the opportunity to be with you all this evening and talk to you about a project that we've been working on for several years. And really, how this came about is just a group of us getting together, talking about what we were seeing in our clinics. So, what I'm going to be discussing is the prevalence of keratoconus in a pediatric population. Specifically here in Chicago, but what's going to be more important is how we came up with the prevalence. So if you have any questions, please let us know, but I'm excited to share with you our findings. So here are just disclosures, but before I get started, I really have to acknowledge the individuals who helped us with this project, specifically the study team members. There was a lot of work that went into this. So Dr. Sandy Block, Barry Iden, John Gelles, Andy Morgenstern, and Bill Tullo. The amount of work that went into this words cannot express the amount of work that went into this. So lots of thanks to them. Also, the International Cares Academy of Eye Care Professionals, ICO, where I work full-time, and then Oculus for their help as well. Okay, so I'm going to start with a case that many of us see every day in practice. So this is a 12-year-old who presented for an updated eye exam. Here in Illinois, anytime that a patient changes school, they come in for an eye exam so that they can get a school vision report. So that was the reason why this patient presented. They're going to a new school and really no complaints with vision at distance or near, but stated that they kind of have this pressure sensation in the right eye and notices it more when the weather changes. But when asking more questions, that sort of makes sense because the patient has this atopic history, has eczema, asthma, seasonal allergies. The patient is also very active, plays a lot of sports, and also states that notices some glare, particularly when playing soccer at night. But the thing that I have noticed when examining pediatric patients is that they don't complain as much as adult patients. Their symptoms are different. Sometimes they can't verbalize it or they just don't complain about it. So their symptoms are going to be different. They might be positioning their heads differently, or they might be blinking more, or maybe you'll notice them even rubbing. But essentially, this patient didn't really complain. And that's just something for us to keep in mind as we're seeing these patients. So when we take a look at the patient's examination information, uncorrected acuities are pretty decent, 20/25 minus in the right, 20/20 in the left. Entrance testing, essentially unremarkable. Refraction is a little different, right? Plano on the left eye, but a little bit of astigmatism in that right eye, but the patient still says it's not super clear. Slit lamp shows papillary reaction, which we would expect with that atopic history. IOPs and dilated fundus exam, essentially normal. Now, thinking about this type of patient that we see very commonly, very often in our practice, the question becomes, would we do any additional testing? And for those of us who are busy, many of us probably wouldn't, right? But sometimes when you sit there and in your gut, you're like, something seems off, you have to trust your gut. And in this case, if we hadn't done any additional testing, we probably would have missed something. So we trusted our gut and we decided to proceed with corneal tomography. And what I want to take a look at first is this left eye, right? Because if we take a look at just the axial map and just the elevation of the front, we probably would have missed this patient if we just did corneal topography, right? Just doing analysis of the front of the cornea. But when we take a look at corneal thickness and especially the elevation of that back cornea, that's where we see those changes. The right eye, we can see more evident there, but this is what I want to stress is if we're not looking for these patients, we're going to miss it. And why is this important is because with pediatric patients, the younger the onset of keratoconus, they're going to have a poorer prognosis because it progresses faster. When it progresses faster, they're going to have more complications. They're going to have an increased likelihood of needing corneal transplant. And if they have a corneal transplant at a younger age, that leads to a higher risk of rejection, right? And with kids, they already have so much going on, but this can really impact their quality of life, their learning opportunities. So we have this ability to really intervene at a much younger age. But again, it leads to we gotta look for it. So then that leads to how common is keratoconus? And when we look at the literature, keratoconus is classically referenced as 1 in 2,000, right? And this is based on a very old study, but it's still referenced. This was based on a registration study in Minnesota. This was conducted between 1935 and 1982. But if you look at this, this was based on old metrics, outdated metrics. It was based on the detection of scissor reflex with retinoscopy and keratometry outcomes. I'll tell you, a lot of individuals aren't doing retinoscopy and they're not doing Ks, right? So this again is outdated information. If we take a look at newer, right, reports, there still is large discrepancy in the prevalence of keratoconus. And if we look at all the data, the prevalence of keratoconus in the adult population, it ranges anywhere from 1 in 50 to 1 in 750. And again, this is due to the metrics that we use. It's based on the geographic location, ethnicity, and some of it, again, is based on the study design. If we look at the Netherlands study, here we see that the prevalence is much greater. It's 1 in 375. But this was based on an insurance database. They gathered many, many subjects, but this utilized topography. They didn't use tomography. They didn't look at that posterior cornea. Moving forward, if we look at the RAIN study, they did use corneal tomography, and they looked at the spinal D, and we're going to get into this in just a little bit, and they found that the prevalence was 1 in 84. But again, the final D was not designed to look at keratoconus. This was designed initially for refractive screening purposes to differentiate abnormal corneas from normal cornea. So this might be an overestimate, right? So as we see here, each study on the prevalence of keratoconus has used slightly different criteria to diagnose keratoconus, and we haven't even touched on pediatric population yet. So there's lots of challenges, and really there is lack of pediatric evidence. So that's how we got to this study. So we were seeing many patients referred for corneal tomography. We were seeing patients with complications. We were seeing patients with high amounts of astigmatism. So that's how really this study came to be. So what was the purpose of this study that we did in Chicago? The entire purpose was to determine the prevalence of pediatric keratoconus using Scheimpflug corneal tomography using more specific metrics. So how this study was designed, it was a prospective observational single center study. And how patients were seen is that this study was set up at a satellite clinic. It was a school-based vision clinic, and subjects were between the ages of 3 and 18, and all subjects, regardless of whether or not they could pay for an exam, were seen. The patients were predominantly low income and primarily 2 minority racial ethnicity groups. And patients had a comprehensive eye exam. They had vision, binocular vision assessment, refraction, cycloplegic exam, anterior segment evaluation, posterior segment examination. And in addition to that, every single patient had corneal tomography done on each eye. And not only is this significant in that we were able to obtain a lot of data on a lot of subjects, but this is also significant in that we were able to capture images on pediatric patients where sometimes we think that maybe kids aren't going to be able to sit for screenings, and they were able to sit just fine. So let's get into more of the methods. And we were talking a little bit about the Balin-Ambrosia enhanced ectasia display, right? And why this is beneficial when we're looking at pathology is because this combines both the anterior and posterior elevation data as well as pachymetric data in all-inclusive display, right? But remember that this was initially designed to screen abnormal corneas from normal corneas. And in previous literature looking at the prevalence of keratoconus in several populations, they use this, but they only use the final D. So in order to improve specificity for keratoconus using the final D, we added the back elevation at the thinnest point. So here are the metrics that we use to diagnose keratoconus for this study. So for normal patients, no evidence of keratoconus, we use a final D less than 2 in both eyes. To consider someone a keratoconus suspect, we use a final D greater than or equal than 2 and less than 3 in combination with back elevation at the thinnest point of greater than or equal than 18 microns for myopia and greater than or equal than 28 microns for hyperopia or mixed astigmatism in at least one eye. And then for keratoconus, we use a final D of greater than or equal than 3 with a back elevation at the points for the same. Okay, so keep that in mind. So what did the results tell us? Well, again, we were able to obtain data from many subjects. We were able to obtain data from over 2,000 subjects. Once duplicate scans, poor quality scans were removed, we had data from almost 4,000 eyes. So that's a lot of pediatric subjects. If we take a look at the population, 56% were female, 43% were male, and the average age was around 11 with range of 4 to 17 years. And again, this population was primarily Black and Hispanic, okay? And here's where I think that's really exciting here. What we've learned a lot, right? If we look at the prevalence, okay, based on the metrics of the Scheimpflug tomography, the prevalence in this population, keratoconus, is 1 in 334. But here is where I think we really need to look at for patients with keratoconus suspect is 1 in 669, but when we combine the two, so the subject's total keratoconus and keratoconic suspect, the prevalence is 1 in 223. And for those patients who are considered keratoconus suspects, those are the ones that we really want to watch much closer. So what does this all mean? What this means is that this prevalence study found that the prevalence of keratoconus is higher than that classically referenced report that people are still utilizing, right? So what does this mean? This means that we need to be screening for keratoconus much earlier. And it also means, right, that those patients with subclinical disease, those patients who are considered keratoconus suspects, we need to look for them because they're going to demonstrate posterior corneal changes or pachymetric abnormalities first before they demonstrate anterior corneal surface changes or before they have vision loss, before we're going to see some of those classic slit lamp findings. And if we're not looking for them, we're going to miss them. What else does this mean, right? We need to be utilizing technology. We need to be utilizing corneal tomography, not topography. If we're just looking again at the anterior cornea, we're going to be missing these subjects. We need to recognize progression, and then we need to intervene early. We need to intervene early so that we prevent progression of this disease, particularly in the pediatric population, because we know when they're diagnosed early, they're going to progress faster so that we can avoid vision loss from keratoconus to really impact their quality of life, right? So again, what can we do? Consider expanding screening, right? Many practitioners, many of us, not just eye care practitioners, but talking to schools, talking to other healthcare professionals to expand screening for keratoconus with tomography, that this should be included as part of the pediatric comprehensive ocular exam. And so that's what we learned from our study, but what are some next steps that we should do, right? So this was one study that we did, and yes, we had a lot of great data, but what else can we do? I think it's important that we do further large-scale multi-center studies to look at more populations, more geographic areas, more ethnic populations, to really understand the prevalence in the general pediatric population, and really look at screening for patients who are considered keratoconic patients and those suspects that we should be screened, included as part of the routine pediatric eye exam, particularly for those who are demonstrating high risk factors such as high astigmatism, reduced visual acuity, and isometropic refraction, family history of keratoconus, that classic kind of history presentation, that atopic history, or aberrant corneal presentation. So those are the findings that we found in our study. I hope that you found this information useful and interesting, and hopefully you'll be able to take something with you back to your clinical practice when you see your patients tomorrow. Thank you for your time.
Thank you, Dr. Harthan, for that great summary of the prevalence study in pediatric populations. Next, I want to talk a little bit more about using the Pentacam tomography for screening for keratoconus, diagnosing keratoconus, and finding out if keratoconus is progressing or doing progression analysis. So these are the displays that we utilize when we're concerned about keratoconus in a patient population. The four displays that are specific to keratoconus are the 4-map refractive, the Bell-Ambrosio display, the topometric KC staging display, and finally the Bell and ABCD progression display. And they're all used for a different purpose. We're going to talk about each of these next. It's important when you look at corneal tomography to understand that you're looking at a two-dimensional image of a three-dimensional surface. So understanding what exactly is happening to the patient's cornea in 3 dimensions is very helpful when you look at tomography displays. This cartoon shows what is actually happening in keratoconus. Now, the two things that we all agree upon in keratoconus is A, the cornea is thinning, and B, the cornea is steepening. So the question is, how do you get a cornea to thin and steepen at the same time? Well, to get it to thin, you can actually move the back surface forward, but you don't get any steepening. You can also move the front surface backwards, but you actually get flattening of the cornea. So what's really happening is both surfaces are moving forward, but the back surface is moving forward at a faster rate than the front. In fact, the back surface tends to change shape before the front surface even has any changes at all, which really highlights why Dr. Harthan said you have to look at the back of that cornea if you want to pick up keratoconus in its early stage. When you look at elevation maps, there's really a visual cue that you're looking for when you're looking for irregular astigmatism. Normal spherical corneas will have a uniform color to them with nothing to see. Normal astigmatism, with topography, you'll see a bow tie, but with tomography, you're going to see this saddle shape. And this is orthogonal astigmatism, so it will be symmetrical left to right and top to bottom. And that's what we see with normal astigmatism. With abnormal astigmatism, like what's seen in keratoconus, we'll see these islands of elevation. And this is what we visually look for when we inspect elevation maps and tomography when we're looking for keratoconus. Now, like a visual field, it's important to know if a patient has fixation errors to know if it's a quality scan. With tomography, we also need to look at the QS or quality specification values to make sure we have a good scan, to make sure the patient didn't move, didn't blink. And while it only takes 1 second to take the image, it is possible to take poor images because of patient fixation. Here we see with the 4-map display here, this has 2 QS values, one for the corneal front surface and one for the corneal back surface. And with the QS values, we want to see white boxes here, not red as we see here in these displays, and not yellow. Your technician should know if you get red or yellow to try to repeat these scans to get a white QS value on the front and the back. Now, what do we do? What do we look for when we look at these 4-map refractives? I'm going to take you through my rubric that I use when I analyze these maps. The first thing I look at is I look at the front elevation maps and I look at the back elevation maps. And what I do visually is I cut the maps vertically left to right. I'm looking for symmetry or any lack of symmetry. Normal corneas will be perfectly or very close to perfectly symmetrical, as we see here in this example. I also look at the top to bottom symmetry, cutting them horizontally, and we also want to see symmetry top to bottom in normal corneas. Once we look at that and we see no islands, we're going to look at next the axial sagittal map and the corneal thickness map. On the axial sagittal map, you see here we have a typical bow tie as we see in topography. The bow tie should be nice and large, as we see in this example. This bow tie is about 6 to 7 millimeters in size, and that's typical of a normal bow tie, the bow tie should also be symmetrical. We see when we cut it here left to right, we see a symmetrical bow tie. We cut it top to bottom, we see the top and bottom are symmetrical also. The third thing we look for too in the bow tie is it orthogonal? Is there any skew of the bow tie? And we see in this example here, there's virtually no skew at all. This is a nice orthogonal bow tie. When we look at the corneal thickness map, we should draw our eyes immediately to the thinnest point, which is this hollow black circle we see here. In normal corneas, the thinnest point should be within 1 millimeter of the vertex normal or the line of sight. And we see in this case here, these two red arrows will show that the distance between these 2 points is less than 1 millimeter. The other important thing is if you look at these colors, these circles of the colors should be fairly round and symmetrical in shape. In normal corneas, that's the way a cornea thickens from its thinnest point out to the limbus. And we'll show you some examples shortly of what abnormal corneas look like. The other important thing in keratoconus is it also needs to satisfy several other conditions. Again, we want to see anterior elevation near the thinnest point that's less than the posterior elevation in the same general location. So it's always important that the back elevation exceeds the front elevation and that the thinnest point is in the area of the elevation. If these criteria are satisfied, likely we're looking at ectasia or keratoconus. The other important thing to note is not only in keratoconus is the eye itself asymmetric, but also the fellow eyes, the thinnest point between the two eyes is asymmetric also. So if we take the thinnest point between the left and right eye and subtract them, if we get more than 17 microns, that's suspicious. If we get more than 25 microns, that's 3 standard deviations, and that's abnormal. So it's also important to compare the two eyes, not just look at the individual eyes also. This is why I always say when people mail me maps to look at, please send both eyes because I can't judge just one eye only. Now, here we have another display I wanted to point out, the topometric KC staging display. And this display is very helpful not only in the diagnosis, but in the grading or the stage of the disease. This staging display takes into 4 metrics into account. That's the A, B, C, D metrics. A is the curvature of the anterior cornea, B is the curvature of the posterior cornea, C is the thinnest point of the cornea, and D is the patient's best corrected distance acuity. And we grade these so that we can watch over time if these are changing and we can classify to mild, moderate to severe disease. We can see this particular patient here, we have an A1, B0, C0, D1. This is a very mild case of keratoconus. As we can see on the 4-map refractive, we have an island of elevation here on the back of the eye and a very subtle one here. We know that 8 microns is abnormal in the front. We have about 10 microns here on the front. This patient probably has good visual acuity, but it's a very early mild case of keratoconus. As opposed to this more moderate case here, we have an A2, B4, C1, D3. We can see here the back elevation is almost 80 microns. The front elevation here is 40 microns. It's in the same location, and the patient's thinnest point is within that area of elevation. This satisfies all the criteria for making the diagnosis of keratoconus. We also see in the axial map severe inferior steepening, again a 58 diopters here and a 35 diopters up top here, so severe IS ratio, and we do see some corneal thinning here also with a 472 cornea. So that's a moderate case, and here's a more advanced case of keratoconus. Here we have here an A4, B4, C2, D2, and again because that anterior cornea is up to an A4, we can see here with this amount of elevation within the pupil, we're going to have significant loss of best corrected vision, which is also displayed on the D2 portion here. The patient is down to 2100 best corrected vision. So that's how the topometric KC staging display is used in conjunction with the 4-map refractive to help make that diagnosis of keratoconus. Now, the Bellin-Ambrosio display is another display on the Pennicam that was originally designed for screening patients for refractive surgery. So what this display actually does, as Dr. Harthan pointed out, it's used to find abnormal corneas, not specifically keratoconic corneas. And I know in a lot of papers the final BAD value is used to determine keratoconus, but not every patient who has an elevated final D has specifically keratoconus. So as Dr. Harthan said, we make some modifications to the metrics to filter out all the non-keratoconic patients. But like the 4-map refractive, it's also important on the BAD display to make sure you have normal QS values. There's a single QS value in the BAD display, and it needs to be white to be able to use the regression analysis properly. If it's yellow or red, again, you make your technicians repeat the scan, and it is possible to have normal QS values on the 4-map refractive and abnormal ones on the BAD, as the QS value is measured differently on different displays. So it's important for your technician to review these displays before they either print them or send them to your EMR. The other important thing your technician should know with the BAD display, because the normative databases have a 8 mm capture diameter as the basis for accepting the data, that we need to capture 8 mm on our patients to use the normal database. Here's an example of a patient where their upper lid, you can see all this extrapolated black dots here. The upper lid is reducing our capture size significantly down below 3 mm. And again, because this is so small, we cannot look at that final D and utilize that to determine the status of the patient. We can see here in the QS value, it's red and the patient was blinking. Again, this map has to be redone. We cannot utilize this to make any clinical decisions. So how does the BAD map work? Well, I'm going to give you a quick summary of what's going on. What this map looks at, it looks at the 3.5 mm to 4 mm zone around the thinnest point. We know that keratoconus is not a disease of the whole cornea, but it's a regional disease that's centered around the thinnest point of the cornea. So that's where we want to focus our attention. So on the left-hand side of the map, what we do is we eliminate that data from the calculation of the best fit sphere. That enables us to do what's called an enhanced best fit sphere, and we can sometimes see the elevations of the cornea easier in our typical views, and we'll show you some examples of how that works. So here's the Bell and Ambrosio display, and this is version 3. On the right-hand side, we have two very important maps, and these are maps that show how the cornea thickens from its thinnest point, the red line being the patient, the black lines being standard deviations. This shows you how we go from the thinnest point of the cornea all the way out to the limbus of the cornea. And we see a normal cornea, and this patient is very normal. The red line mimics the black lines very, very closely. And we can see here that that's how a normal cornea should look. Down below in the PTI graph, we see the same calculation except in percentile. And in percentile, we see how it increases as we go from the thinnest point all the way out to the limbus, and it stays nicely between those standard deviations. So that's a nice normal eye, and that's how we use the corneal progression maps, or the CTSP, and the PTI maps. On the left-hand side, as I said before, we have our elevation maps. In fact, we've got 3 of the 4 elevation maps seen on the 4-map refractive. The front elevation, the back elevation, and the corneal thickness map are all seen here. What we do on this left-hand side, though, is that Bell and Ambrosio enhanced ectasia map. So what we do down here is we take that data out around the thinnest point and we replot the graph. On normal eyes, you'll see virtually no difference between the normal elevation map and the enhanced map. And in fact, if you look down below, this is a difference map of the two. And we see here everything is green and normal. Nothing lights up yellow or red. Same thing on the back of the cornea. That's the regular elevation map, and this is the enhanced back elevation map, and that's the difference between the two. And this is just an example of what a normal eye will look like. But finally, the most important value is this final D value. This is a result of the regression analysis of 9 important variables, each of which is weighted differently. And so what we see here is a number that's either white, yellow, or red. And simply put, yellow is suspicious, red is abnormal, and white is normal. Again, this is based on abnormal eyes, not specifically keratoconic eyes. One additional factor that your technicians must utilize is we have two normative databases, the default databases for myopic eyes. As this display, again, was designed for refractive surgery, the vast majority of patients having refractive surgery are myopic. But we know that we use the screen for other eyes that are not myopic. So we have a second database called our hyperopic or mixed astigmatism database. It's important that your technicians manually switch this over. Here we see a hyperopic patient that's actually screening suspicious on the final D value, but look, this was the wrong database. If we switch this over to the correct database, now our patient is screening a normal range. So very important that your technicians utilize the proper database before they send you the maps. So again, to summarize the BAD or the Bell and Ambrosio display, it's designed for early detection of abnormal corneas, and it's very useful for screening patients before refractive surgery. The final D cutoff values for white are less than 1.6, yellow is 1.6 to 3, and red is any values above 3 on the final D values. And again, remember, this can only be used for untreated corneas, corneas that have had no prior surgery or no alteration by any means, including a contact lens. And here's just what's behind the regression analysis. Here are the 9 different parameters that are used, and they're all weighted differently. And each of these parameters have some specificity and sensitivity, but none of them are individually predictive of abnormal corneas. It's the combination of all 9 of these that actually give us that final D value that is uniquely predictive of abnormal versus normal. And here's the ROC curve. If you're familiar with ROC curves, this shows you the sensitivity and specificity of a specific metric. And we see here with the 3 version, we have 94% sensitivity, 94% specificity, a very excellent diagnostic tool. Now, if we look at for the definition of the diagnosis of keratoconus, we need to look back at a landmark paper from 2015 published in Cornea by Gomes and his Delphi group of experts on keratoconus and ectatic diseases. It was the global consensus paper, and that paper showed us that there are 3 criteria necessary to make the diagnosis of keratoconus. And this is really important to understand because they show us that abnormal posterior elevation is necessary. Abnormal corneal thickness distribution, as we saw, here's an example of a patient with keratoconus. Look at the red line, how far down it droops below the 3 standard deviations. And we also need thinning, non-inflammatory thinning of the cornea, which we can see on our Scheimpflug image or on our pachymetric maps. Again, if we want to diagnose keratoconus early, and now that we have a definitive treatment that's safe and efficacious in corneal crosslinking, it really behooves us to find these patients as young and as early as possible before they lose vision, because we can stop this condition before it affects patients' quality of life. But again, because this starts in the back of the cornea, corneal tomography is essential in finding this disease. And this is just the rubric that Jen showed us earlier. Again, this is just what we use to combine the final D values with the back elevation at the thinnest point for myopic patients with 18 microns, hyperopic patients 28 microns. This allowed us to take the BAD maps and take it from an abnormal to normal distinction and filter out only to the keratoconic eyes. Also, it's also important clinically when you're in your clinic also to look at a lot of other factors. Those factors include delayed asymmetric corneal astigmatism, reduction in best corrected vision, or asymmetric best corrected vision that's not explained. We talk about the abnormal tomography, but we also should take a peek at aberrometry because we tend to see elevated vertical coma. 0.3 microns at a 6 millimeter capture tends to be our cutoff for vertical coma, but also compare that in each eye, compare left and right eye. We'll see asymmetric coma in these early keratoconic patients. Always ask about family history, ask about eye rubbing, atopy. Again, get histories of their spectacle corrections and look at those unilateral refractive changes that occur over time. or those patients in the contact lens where one contact lens doesn't provide clear vision, and all these changes in lenses really doesn't result in quality vision, and also genetic risk factors we can look at also. I want to close with just talking about progression, because right now in the United States, in order for us to get insurance to pay for cross-linking, we need to show progression. And the Delphi panel was really wonderful in showing us the definition of what progression is also. They told us that you need to find at least 2 of the 3 following parameters to show progression, and that's steepening of the anterior corneal surface, steepening of the posterior corneal surface, or a progressive thinning or increase in rate of thinning. That's basically the pachymetric progression maps showing that the cornea is thickening at a advanced rate because there's a thin point on the cornea. So any 2 of these 3 would be enough to show progression of a cornea. And again, the ABC display for progression utilizes exactly the opposite data that the BAD uses. It takes a look again at that 3 to 4 millimeter area and will focus on that area only. So instead of excluding the data, it only looks at this data because that's where the disease is. And if the disease is progressing, it's going to be found in that area 3.5 to 4 millimeters around the thinnest point. And the way the display works is it aligns various patient exams over time. And again, we see the A is the anterior cornea, B is the posterior cornea, C is the thinnest location, and D is the best corrected vision. We see the dates of the exams in this patient had 3 exams, 1 in 12, 1 in 14, 1 in 16. We see here the yellow being the first, green being the second, blue being the third. And then again, we see here the 4 values. But probably the most important part here is the staging and the normative data that we see here. This is the baseline scan, the first ones. And we have these different flags or gates that we see here. The green gates are when a patient has not yet had the diagnosis of keratoconus. So this is a normal population of normal eyes. And we see we have an 80% gate and a 95% gate. And then we also have the red gates here that are a keratoconic population. We have an 80% confidence interval and a 95% confidence interval here. And here's just an example of a patient who's a young 15-year-old with early keratoconus. We followed this patient over about 13 months with 3 different examinations. And we noticed with the front of the cornea, we see no significant change in that front of the cornea here. It doesn't exceed either the 80 or 95% confidence interval. But look at the back of this patient's cornea. From exam 1 to exam 2 exceeded the 80% confidence interval. Exam 3 exceeded the 95% confidence interval. And then if we look at C, the thickness of the cornea didn't really change very much, and the best corrected vision maintained at 20/20. And also take a peek at K max. Because the front of the cornea didn't change, K max didn't change at all. And I have found that a lot of insurance companies will look at K max as a determiner for payment. We know that this patient is progressing. Look at the back of this cornea. It's only a matter of time till the front of the cornea will follow suit and do exactly the same thing. Our criteria for diagnosis of progression is if any 2 parameters exceed 80% confidence interval or 1 parameter exceeds 95% confidence interval, as in this patient's back cornea does, that's progression. And this is what I would use to help a patient. And here's a patient that's been cross-linked. Once you're cross-linked, you'll see the stippled line and the date of the cross-linking, and then a new third database will appear in these blue gates. And you see the blue gates have an 80% and a 95% confidence interval also. This helps us establish after cross-linking, is the patient stable? It's very important. Even though cross-linking works in the vast majority of patients, there are some patients where cross-linking may need to be repeated. So these blue gates help us know if a patient is stabilized. We can see this blue exam was an exam after cross-linking, and we can see here there's no really progression on the front of the cornea. It hasn't even reached the 80% confidence interval, the blue gate. And on the back of the cornea, we actually see flattening improvement. And again, nowhere near the 80 percentile gate. And on the corneal thickness, again, we see no considerable thinning of the cornea, and again, has not exceeded the 80% confidence interval. So we know this patient is stable after cross-linking, but they need to be continually monitored over time to make sure. Thank you very much, and here's my email address if you have any questions, and my cell phone number.
Okay, welcome to the webinar here for the Cam being utilized for orthokeratology and myopia management. This is my disclosure slide. I do consult for Oculus and Wave, but I'm primarily a solo private practitioner. My practice is a contact lens only practice, and it's mostly focused on irregular corneas and orthokeratology and myopia management. That's virtually all I do. I do offer various forms of support to fellow doctors through private consultation services. I've done some beta testing for the CSP and Wave software as well as the AXL Wave hardware. I did design up the first Wave Designers Certification Program, worked on some Wave scleral lens design AI, and I'm guiding the Wave training and Wave software development. Now, what we're going to talk about today is a case presentation. It's an orthokeratology case, and it's for myopia, and it started back in February 12th of 2003. And we had a 14-year-old white female who came in wearing no glasses. She had broken them, and the uncorrected acuity is about 20/70 plus in both eyes. Manifest refraction, you can see there, is low myope with a bit of cylinder, and she corrected to about 20/25 minus in each eye through that. Health was good. She wasn't taking any medications or have any allergies to any medications, and there was nothing else that was unusual about the exam. A couple of years later, she came back in after getting that pair of glasses in 2005. She's now 17 years old, and once again, she had broken her glasses. She now uncorrected was a little bit worse, 2100 and 2080 plus. And you could see the prescription is a bit different. I've put the previous prescription up there. You could see the cylinders changed, the minuses changed, but roughly she's about equal in spherical equivalent. And again, she corrected to 20/25 minus. Still in good health, no medications or allergies, and nothing else going on. And here are her topographies for that day. You can see there's nothing unusual, maybe a little bit on the flat side, but very, very normal type of topographies. And she said that she was now interested in contact lenses. You can see there the simulated Ks showed about a diopter with the rule cylinder, so that agreed reasonably well with the refraction. And I went ahead and designed up a pair of Wave single vision GP lenses to be worn for the daytime. She did very, very well, and again, best corrected to about 20/25 minus in the GPs. So this was in August of 05, and she came back a little less than a year later in 06. She broke the left lens, but she had been doing very, very well. And you can see now that her uncorrected acuity had dropped even further. She's at 2400 and 2100 minus, respectively, in each eye. Refraction, though, again, it's a little bit different. She's showing a little less cylinder in both eyes, but spherical equivalent, again, she's about the same, but the acuity definitely is a little bit worse in the uncorrected state. Health is good, medications are good. I mean, not taking any medications, and she didn't have any allergies, and the rest of the exam was unremarkable. Here are her topographies again, and you could see not a whole lot of change from what we had seen previous year. A little bit on the flat side, but very normal, plain type of topographies here. So I discussed orthokeratology with her as an option, and once again, the simulated Ks are showing the about one diopter with the rule cylinder, which was a decent correlation with the refractive data that I found that day. And so I put her into orthokeratology, and her results, we actually got a little bit better on corrected acuity at 20/25 plus now, instead of 20/25 minus in each eye. And here are her treatment topographies, and you can see they look very typical of an approximate -3 myope for the distinction of the reverse curve red ring, as well as how much has been flattened centrally. Skip 10 years later, she's now about 28 years old. She's been in orthokeratology for 10 years. She's done very, very well. The current lenses she's wearing are 2 years old. But you can see her uncorrected acuity is down a little bit from what I had previously. She was 20/40 plus and 20/50 plus with a little bit of residual refraction. The right eye took a minus 175 that got it to the 2025, and the left eye with a little bit of cylinder at an oblique axis actually got it at 2020 minus, but the lenses were a couple of years old, so I had attributed the decreased acuity to the quality of the lenses treatment. You could see here topographies on top were the ones from back in 2006, and the ones on the bottom are from 2016, 10 years later. They don't look a whole lot different, but you can see the ones on the bottom just a little bit less clean looking, again, probably owing to the two-year-old lenses that she was wearing. So I replaced the lenses, and we jump now a couple of years later. She's at 11 and a half years out. These lenses are 1.5 years old from the replacements I had given her. And once again, her uncorrected acuity is back to 20/25 minus in each eye. Again, there's a little bit of a residual refraction, but the lenses are 1.5 years old. And so once again, I was going to replace the lenses. But looking at the topography, you can see here, again, the one on top is from back in 2016, and here about a year and a half later in 2018, the ones on the bottom. The right one is definitely showing some sort of little central island there. The left one is actually not looking all that bad, and you can see that with the residual refractive data added in, she was actually back to 20/25 plus. So I went ahead and replaced the lens, and I asked her to please come back right after she got the new lens so I can see what kind of results we would get with the new lenses. So very typically, she disappeared for another couple of years. She's now 31 years old. I never got to see her with the lenses being new. And these are her 14-year orthokeratology results. Again, the lenses are 2 years old. The right eye's at 20/30 plus now, but again, with the residual refraction back to 20/25 minus. And the left eye, 20/30 minus, but now it doesn't really get any better than 20/30 minus. And if we take a look at the maps, you can see the 2018 maps on the top and the 2020 maps on the bottom. And the right eye is definitely showing that little central island there that's definitely more well formed. Again, the left eye doesn't really look that bad, but she is only getting to 20/30 minus. A little bit after the 2018 examination is when I got the Pennicam put into the office, and so here now in 2020 I wanted to go ahead and run her on a Pennicam scan, and so here are the Pennicam scans that I got for her that day. And the first thing you can notice here is pachymetry is showing very, very thin corneas at 435 microns on the right and 454 microns on the left. If we take a look at the enhanced ectasia display, we can see that there's definitely some abnormalities here on these corneas. And if we look up over on the elevation on the back surface there, you can see that the right eye is definitely showing some significant thinning, and on the difference map there at the bottom, you could see there's a little bit of a central area that corresponds roughly to where I was seeing that island pop up on the orthokeratology treatment. The left eye is a little bit below the radar there, but still showing a little bit of abnormality. So to recap, we started back in 2006 with these topographies, 17 years old, and those topographies would be very, very hard pressed to evaluate for keratoconus at this point. They looked very, very normal, a little bit flat, not a whole lot of cylinder, and it was with the rule cylinder. And you could see with the refraction, the 250 minus 75 and the 2 1/4 minus a half. I mean, she's roughly a 3 diopter myope with a very low amount of cylinder. She gets a 20/20 minus with that. There was nothing unusual going on health-wise, and there was nothing in the rest of the exam that would have pointed to keratoconus. And once again, if you look at the simulated Ks, they do represent a particularly flat cornea with 1 diopter with the rule cylinder. So there was nothing really as a tip-off here to indicate that there might be an underlying concern for keratoconus. And it took until she was in her young 30s to pick this up. So this really would have been a much better handled case, I believe, Had I been able to get some of that pentacam data back when she was 17 in 2006, I don't know that we would have gone down the orthokeratology route. We probably would have discussed things like crosslink that are available today. That was not obviously available back then when this case was done, but this really would have helped guide her clinical treatment a little bit better, as well as answer the question when she started to develop some of the decreased acuity uncorrected from her orthokeratology treatment as to why that was actually happening. Again, the younger crowd that typically is being put into orthokeratology for myopia management, getting all of these metrics on the cornea prior to starting orthokeratology, I think this case really underscores just how important that really does become, because it really can change an entire management plan as to how you're going to take care of this particular patient. Thank you very much.